L2, L3 means 3. Okay, lectogenesis 1. Now we have to place, where is it starting? In the pregnancy, after the pregnancy, or what time? Definitely you can see the picture, you can see the slide. Is it coming during? Okay, because it has to begin in pregnancy. It's logical, even without thinking you can answer. Okay, so the first thing is pregnancy, so L1 should begin. The question is, where is L2 mawjood? Is it in the pregnancy also, or it is after the pregnancy? We have to see that. Look at the time. Can you see this one? This time? This is the L1 time usually, lectogenesis 1. Then it fades, it remains very low level because inhibition of the prolactin is there. Prolactin is inhibited by estrogen and progesterone. So this is the time, 16 to 22 weeks usually, and it fades off really. It can come back whenever needed. If the baby is delivered early, okay, the breast is ready taqriban, okay, and quickly the prolactin levels are good and the feeding can be started because all the preparation is mawjood. From 16 to 22 weeks you are doing the preparation of lectogenesis also. Okay, now you see at the time of birth, here this is the time of birth here. After that, shortly after that, you will have a phase which is known as lectogenesis 2. Okay, not on the very first day, because you want some flow of the milk. For 1 day or 2 days the free flow of milk is not available. A very thick kind of secretion is coming. I told you it is colostrum. Very good, very well developed for, and yeah, for the nutrition purpose and for the baby. Baby is quite happy, well fed and well protected by the immunity also of the mother, passive immunity of the mother. It's coming. So after that 2 days or so, then a flow of the milk starts. The true milk form really starts coming with a free flow, and that is your lectogenesis 2 time in mother. Okay, and that goes for some time, and it usually for a couple of days this phase is there for that flow. About 1 week or so this phase is plus minus, yani you have lectogenesis 2. All right, and then after that you have the maintenance phase coming, and that is your phase of lectogenesis 3. Okay, so just after Vilada, wait for some time, 1 day or so, then you have the true lectogenesis 2 phase, the free flow of milk, and it remains for like couple of days, from 2 days to 5-6 days and variably, and then after that it continues on and on and on as the mother is feeding the baby. That is lectogenesis 3. So the tawil phase out of these 3, what is the most? 3 definitely. After that the second one is 1, and then 2, because 2 is a short phase really, few days only, right? L1 again, it was taking time for weeks and weeks. Okay, 16 weeks to 22 weeks, yani taqriban 5-6 weeks are there, isn't it? Okay, so if you are seeing the time of L3 is variably long. It can be long. Some mothers don't go for the L3, you know that. Okay, some mothers, and they have a very short L3 also. They feed the baby for a few weeks only and they say, no, we are having some problems and we cannot do that. They are afraid, they think the milk is not coming properly, other problems also, and they switch on to the bottle feed. Okay, at the start, as the baby switch on the bottle feed, the breastfeeding goes slowly down and down and down, and the baby is totally reliant on the top feeds. So the top feeds will replace the breastfeed, and story stops after 6 weeks or 8 weeks. The breast is, it's finished, it stops really. Okay, it's the ablactation. Ablactation means stopping. Okay, now the question is that what is happening to the hormones basically? Here in this time, prolactin was not free to work. Before pregnancy, prolactin was mawjood. Okay, it was not free. After birth, prolactin is free because placenta is gone. No estrogen, no progesterone, no problem at all, no antagonist. There is no mukhalif left now, there is no opposition. So prolactin is relieved from inhibition. It will work. Prolactin has a very good effect in milk secretion, and whenever the mother feeds, prolactin levels rise really. Okay, the prolactin levels keep on rising. Look at the level, the graph of the prolactin, okay? This is the basal average graph which is coming on. At the time of the birth, when the estrogen and progesterone are removed, look at the height, okay? It is very high for some time, and then slowly the levels are decreasing, the baseline is decreasing. But this decrease does not mean that the milk is not produced, please. This is the baseline. Whenever the mother feeds the baby, it will go up, fluctuations will go up on this line. This is your baseline. So baseline is slowly moving down, okay, over time and time and time. But whenever the mother is ready and she feeds, all of a sudden prolactin release increases as a reflex. And that gives a very good amount, enormous amount of milk for the baby. No problem. Okay? So now are the phases clear? 1, 2, 3? No problem with the phases? Okay? So this phase is dependent on the prolactin and it is not dependent on any other hormone for the milk secretion, basically production and secretion, filling of the milk inside the breast. Okay? L3, some local factors or the local control is also important. Some local growth factors, some inhibitory factors are also there for the L3. Okay? Okay. These are the attributes of prolactin. You know where is prolactin coming from? Pituitary, lactotropes. Okay? From the pregnancy, right from the middle of the pregnancy, even in the middle trimester of the pregnancy, prolactin levels are there, but as we say, prolactin is not very effective at that time. We know the reason why. Okay, leave it. Prolactin will have its role in the future when the baby is born. Okay, so prolactin is no problem at all. Now, prolactin is secreted by a reflex basically. Okay, and look at this one. Okay, after birth, when you have a fall in the basal level of the prolactin, there is no problem. Whenever the mother is feeding the baby, look at the graph of the prolactin. It will go up and will come down. Okay, it will go up as long as she's feeding, going up and coming down. So this phasic secretion is great. You don't want secretion all the time. You want secretion only at the time when the baby is required to be fed. As the baby suckles, the process starts and the milk secretion begins and the milk flow begins and it's done. Okay? So look at the consistency of the cycles. These cycles are not becoming weak. Are they becoming weak? No. They are very good spikes which are coming for the prolactin. It's not that these spikes are also becoming smaller and smaller and smaller with the time. Okay? These are the good spikes. Look at your basal level. The basal level has dropped, but the spikes are very good. Okay? All right. Prolactin actions, done. We are done with the actions of prolactin. One thing which is very important, which is related to the hyperprolactinemia also. Okay? We have few things. In hyperprolactinemia, there is a problem. What is the major complaint of the female who is coming and suffering from hyperprolactinemia? What do you think? Amenorrhea. Now you have to find why amenorrhea. What is wrong with the lady? She is having a trouble with prolactin. Why is she having amenorrhea? Is it prolactin induced amenorrhea? If so, why? What could be the reason? Why? Please. Mobiles, please. Take care of the mobiles. When others are respecting, all should. Okay? Have a serious attitude in the class, please. Thank you so much. All right. So, the idea is link prolactin with the amenorrhea. Okay. It has some effect. Well, okay, it's a negative feedback kind of effect. So what is it doing? It's excess of prolactin, very big amount of prolactin. Yeah. Inhibition of gonadotropin. Where inhibition exactly? What? Hypothalamus. Okay. One answer is coming that High levels of prolactin will affect hypothalamus. What could be the other answer, possibility?
It has an antagonizing effect on the FSH and LH.
Mm-hmm.
So
Okay.
it will antagonize the effect of these two hormones. So we'll know menstrual cycle will occur.
Okay, Abdullah, what level do you think are they antagonizing? Okay, are you talking about the pituitary level or are you talking about the ovarian level? Ovarian level. Okay, it is a known fact that somehow at the level of receptors, prolactin is causing some resistance to the work of FSH and LH, and they don't allow the follicles to grow actually and ovulation to happen. So one thing. So this action is peripheral action or a central action? Peripheral. But do we also have a chance of having central action? Yes, okay. So it's a combination perhaps of central action and peripheral action. Acting on the hypothalamus and pituitary, prolactin is doing something, and it is also inhibiting at the peripheral level. When you are blocking the hormones at two levels, double level, imagine what will happen. Do you think FSH and LH can work properly? First of all, they are not secreted properly. Secondly, they will, even if they are secreted, they will not work properly at the ovarian level. Okay, and that is why ovulation is not induced and the cycles do not start. We don't have the reestablishment of cycles. Okay, that is about the prolactin. So prolactin is the antagonist of these hormones in high amounts. Okay, and if you see, prolactin itself is antagonized by estrogen and progesterone also. Okay, so there are some opposites or the enemies of the prolactin also, which are estrogen and progesterone. Okay, for some specific time. Males, what does prolactin do? It's difficult to say. Normally, what is the function of prolactin? We have not come across the normal function. Some function in reproduction, we are not sure about that. In fertility, we are not sure about that. But one thing is for sure, excess of prolactin is causing the harm to us, and excess leads to infertility, subfertility to infertility, causing a problem sometimes. And one more issue is also a function, a sexual function problem, which is impotency. Okay, there is an issue of failure to have a normal sexual act or erection also in excess of prolactin. Okay, so it is doing something along with the male sexual act also of the erection phase. Okay, or it is affecting the time of the refractory period between the two ejaculations also. So prolactin has something to do with the male sexual act more than the fertility actually. Okay, for the control of prolactin, one thing please. Okay, I am not going in detail. Prolactin is controlled by a special hypothalamic hormone or a chemical. What is that hormone which is controlling the prolactin? Is it inhibitory factor or a releasing factor? Now see, okay, let me say a word about it first of all and then try to give an answer for that. We are not sure that prolactin has a double control of releasing and inhibiting. Okay, one control is definitely dominant, the other control is a sawal, still a question mark really. We are not sure about it. Okay, whether it truly exists, if it's so, what is that? We don't know really. Okay, but one thing we definitely know, prolactin is dominantly suppressed by or inhibited by one very, very important hypothalamic factor or a hormone like substance. What is that? That is dopamine. When we saw it, that is chemically a dopamine. Yani dopamine is the controller of the prolactin. If dopamine is majood, prolactin is not going to be released. So dopamine is inhibiting or controlling the prolactin. If this dopamine is not majood, the other name of dopamine is prolactin inhibiting hormone, PIH, prolactin inhibiting hormone. If you remove this effect of dopamine or prolactin inhibiting hormone, the the prolactin from the pituitary, now it's free, now I'll go. Okay, so it means you are controlling the prolactin with the help of the dopamine. All right, if you have a use of anti-dopaminergic drug, I am giving you an anti-dopaminergic drug for your illness for a long time, what will happen to prolactin secretion? Increase or decrease? One thing. I'm giving you anti-dopaminergic drug, which is acting strongly on the dopaminergic receptors or controlling dopamine, all right? Inhibiting. Anti-dopaminergic. So what will happen to the prolactin? It's a release inhibition, isn't it? It is released. So what will be the side effect of the anti-dopaminergic drugs, my dear boys? Yes, hyperprolactinemia, and if it continues for a long time, what will happen in a female? And what will happen in a male? Impotency can happen. And one more thing can develop in the male, okay? That is, yeah, slight development of the breast, gynecomastia-like condition can develop in the breast. Because when excessive prolactin is there, some growth of the secretory tissue will occur. Normally we don't have the secretory tissue. We have alveoli, we have ducts, we have a little amount of fat, variable amount of fat, depends from person to person, but still our shape of breast is not like a female shape of breast, okay? Still, because our duct system and glandular system is totally infantile or a childlike, okay? We don't need that actually, okay? So if there is a hormone coming, prolactin coming in very large amount, even for the males, it will cause a slight development or increase in size of the breast, and that is gynecomastia-like problem, okay? In females, amenorrhea galactoria syndrome can happen, and in males, it's gynecomastia along with impotency or the sexual issues can arise, all right? If I am using, I have a patient of Parkinson's disease, okay? And for Parkinson's disease, there is deficiency of dopamine, okay? So I will give dopaminergic drugs or the dopamine for the treatment of Parkinsonism. What will happen? What will go wrong with the prolactin release? So you have to take care of that. If you are giving dopaminergic drugs, what will happen to your prolactin? If you are giving anti-dopaminergic drugs, now what will happen? Okay, take a balance and control the side effects, please. Okay, that is important for a female who is having Parkinson's disease, isn't it? Okay, the rest is easy. Okay, all right. Two more terms coming up very quickly. I am just going for the two terms. One term is galactogogues. Okay, gogues are the stimulants which increase the secretion. Galactogogues are those substances which will increase the milk production, okay, and definitely the secretion. So galactogogues are some substances. There are some drugs. One drug is a very famous drug called, I don't know if you have done antiemetic drugs in GIT. Have you done GIT? Yes. There is a drug, very famous one, known as metoclopramide. Metoclopramide, okay? That is anti-dopaminergic drug. What will it do if it is doing blocking the dopaminergic receptors? What do you expect? It is used for vomiting actually, okay? But a side effect of that drug, another effect is that it will increase the prolactin, isn't it? And if you want to increase, a mother comes to you and says that, doctor, I have a problem, I feel that my baby is not getting enough feed, even though I'm eating good, I'm trying, I drink plenty of fluids, asirat, milk, everything, water, and I eat food, still I feel that my baby cries most of the time, and I feel the baby remains hungry, and probably the milk production is less. So as a doctor, if you want to choose a drug which you can give, you can choose a safe anti-dopaminergic drug in a genuine case, not in all cases, okay? Just don't listen to the mothers. They have a little problem also. A mother always feels that the child is not receiving enough amount, even though the child has become like this. See, my child is very weak, okay? All mothers are like that, okay? When they're looking at their children, they seem that the children are babies actually, first of all, whatever your age is, okay? Mother is mother, you know that, okay? The second psyche of the mother is that she feels that the boy or the girl is not very well fed actually. So many of the mothers, when they come, first don't listen to their complaint. Ask few questions, intelligent questions. If you feel that there is a real problem, then you give the drugs, otherwise don't give, because there are side effects of the drugs for the mother and for the baby also. It's not easy really, okay? So take care of that. So metoclopramide is one of the drugs which is used for, yeah, galactogogue. Some of the mothers on the other side, there are problems, okay? You know, sometimes in some of the areas of the world, I'll not blame mothers really. Sometimes they have to be blamed also, but at other times not. Some mothers really are so poor that they have to work at other places even though they have their own babies, but they cannot take their babies along, and they have to work from morning to evening outside to gain bread for the family, okay? And it's a very poor condition. Sometimes outside in the West, mothers, they don't want breastfeeding of the baby. They say, "Khalas, no, okay? It will cause the disfiguration of the body, our figure will be disfigured, and we are engaged with the baby for most of the time. We can give the top feed also, and we are working in the office. We have to start the job after 2 weeks or 3 weeks or 4 weeks of leave. We have to start it again. So at that time, if we are staying from 9 to 5 in the evening, so how can we feed the babies? And our breast is engorged with the milk, and there is a problem in." So, doctor, can we have any drug which can decrease the milk formation so that it stops and doesn't cause any production or formation of some nodules or something like that, or pain in the breast? Well, the doctors do that also. And as a doctor, if you feel and the patient is genuine and she wants that, you can give some of the drugs which will suppress the milk production, and these are called the drugs or the milk suppressant drugs, and this phenomenon is ablactation. You are suppressing the milk production. This is also very common. You will use some of the dopamine agonists. Now you have the concept of dopamine antagonist and agonist, and its application during lactation time. How do we use that? Okay? All right. Leave it. Prolactin production is a reflex. The baby suckles, sensory impulses via nerve fibers go to the hypothalamus. From hypothalamus to pituitary, prolactin is released and the milk comes. And look at this reflex. What an unusual reflex. The baby is touching and suckling. Sensory nerve fibers. So every reflex has sensory part and the motor part. Look at the sensory part. Is it going by the nerves? Nervous. Look at the motor part. Hormones are coming in the blood. It is hormonal. So this reflex is not a pure nervous reflex. It's a double reflex, 2 in 1. You call it neuroendocrine reflex, isn't it? Okay, that perfectly fits into the example of the neuroendocrine reflex. Prolactin secretion reflex. Okay. Is prolactin causing the milk to come out of the breast, or is prolactin causing the milk to be secreted inside and filling? I think the time is up for you for the practical.
Yes, but I'm answering.
Yeah.
I want to answer. Oxytocin.
Yeah. So please keep aside. Prolactin means you are increasing the release of milk from the factories, from the alveoli into the ducts. Yani lactiferous ducts are filled with the milk, but the milk is still present inside. It's not barra actually. It's not outside yet. Okay. Coming out is the job of another hormone. You know that. That's oxytocin. Okay. All right. Now, this is the prolactin reflex. Leave it. If the mother is in stress, she is very tired and stressed, what do you think? Milk production increases or decreases? It should decrease. So the hypothalamic factors, stress or emotional distresses, will decrease the production of the milk. Okay? Read the factors which are there. Okay. There is one more thing. In the breast, when the milk is filled, the milk contains an inhibitory factor. Okay, that's a very special point, please. A very special point. Please. The milk is full in the breast. Milk contains an inhibitory factor, local factor secreted in the milk, and that factor will fight against the prolactin. Okay, locally. You know, the prolactin is coming in the breast and it will act on the receptors. All right. This inhibitory factor which is موجود in the milk, when the milk is موجود, is called here. Okay, this FIL, this one. Okay, it's a local factor which is there, and that is called the autocrine control. This is special. It's the feedback inhibitor of lactation. FIL. F for feedback, I for inhibitor, L for lactation. Okay, now look at the nature, how the nature has made the arrangement. When the milk is already full, do you need extra milk from? No. It means you have to have some feedback. Automatically a feedback inhibitor is موجود in the milk, and that feedback will actually prevent the prolactin, extra prolactin, from acting on the breast more and more release of the milk. So this will act on the receptor level of the prolactins and will try to block. As the baby is fed and the milk is removed, what will happen to the feedback inhibitory? It will decrease, and automatically prolactin is now free and it will work again. So when FIL is موجود, prolactin has to stop its work because already the milk is موجود in good quantity. When the baby has the milk or suckles the milk, now the milk is decreased, FIL is decreased, and prolactin is again now موجود and free to work again. So this cycle goes on and on. If you have more milk, then there is inhibition. If you have less milk, then inhibition is automatically removed. Did you get that? Okay. Quickly coming to the last part, we are talking about the oxytocin, my dear boys, and let's do one more thing as a last issue. It's about the oxytocin. You know the function of the oxytocin. Oxytocin is, are you with us? I don't think so. Check it out, please. Okay. So, oxytocin. Now, milk ejection reflex. What should you name the reflex of prolactin? Give me a name. No, I'm telling you, oxytocin is milk ejection reflex. Okay, khalas. Go back. Go back to milk. Get a better word for that? Thank you very much. Now it's finished. Milk secretion reflex. Okay. Very nice. Okay. The milk secretion reflex, which hormone will come in your mind? Milk ejection reflex. Ejection means coming out of the breast. When you express it, if you express it and it comes out, or it is shown on the surface, this is called milk let down. Let down. Okay. So if anyone asks you what is milk let down reflex, you say khalas, it's oxytocin reflex. If I say milk ejection reflex, nafso, you'll say same thing. Okay. It's the oxytocin reflex. Okay. But when I say no, I'm talking about the milk secretion reflex. It's prolactin. What should be common about these two reflexes, milk ejection and milk? Okay. Yeah. What is common? Stimulus is common. Okay. What else is common? Okay. Feeding. Okay. Feedback. Okay. Yes. In one word, just enclose this. Say both are neurohormonal reflexes. Both are neuroendocrine reflexes, one by one, and they are operating side by side. When mother is feeding, do you think only one reflex is operating? Both are operating at the same time. Okay, take care of that. Oxytocin is very, very unique in some of the regards. Okay, some conditions increase the oxytocin release. Okay, very important. One thing is the sensory stimulus, or when the mother starts breastfeeding. Okay, the baby, suckling, that is the most important stimulus. Apart from that, mother has some other stimuli also, okay, which are not the tactile stimuli. Cry of the baby. What else? These are tactile, sensory. Okay, just touching her breast, touching her nipple, milk will come out. Okay, that's okay. Baby touches, same thing. That's sensory.
Suckling the nipple by the baby?
Yes, it is done, but it is sensory, right? Apart from that, apart from tactile stimuli, touch stimuli, apart from touch stimuli, you said crying of the baby. Mother is hearing, it's going from your system into your limbic system, from cortex to the hypothalamus, and hypothalamus to pituitary, and it's coming. So again, from this pathway, auditory pathway, hearing pathway. Great. What else? Eye, visual. It's an inherent love for the baby. Whenever the mother looks at the baby, it's a love. It's a flood of love from inside. Thinking about the baby, just looking with love at the baby, automatically brings a drop of milk over the surface of the nipple. The reflex has begun. The reflex has started. This is the gift of Allah, actually. It is the bond between mother and the baby. Okay, so Third thing is listening, 1, visualizing, 2, what else? Crying is